Hi guys, I hope everyone is doing great. Once again, Dr. T speaking. So guys, I want us to quickly do an overview of a breast mass. Obviously, this is a surgical case that we are doing today. So this is going to be an overview, guys, an overview. Breast pathologies are a lot. Like there are so many things that can present with a breast mass. So I would encourage you to just follow the guidelines that I'm going to put and go on and study deeper than we're going to do here. So let's quickly run into it. This is an overview, guys. Overview of a breast mass. So if a female comes in with a breast mass, what are we going to do? So it's a mass. So what are we going to do? We're going to take history. So on the history, what do we want? We want to know how long has the mass been there? And the mass, is it painful? Does it come and go? Or is it cyclical? You know, some women, when they get their periods, they get painful breast and then they feel a mess. And when they are done with their periods, they become fine again. So estrogen has got influence. It's the one that causes that. So it has got influence on how breast develops, and so it's a hormonal influence basically. So we want to know if there was a history of trauma a few weeks back. Remember, if you have had breast trauma, you can develop necrosis, fat necrosis that can form a mass there, or even a hematoma that comes. Then the patient comes and then they've got a mass that is painful just because of the trauma, only to find out that it's fat necrosis or hematoma. You want to know if they have a nipple discharge. And if they have a nipple discharge, you want to know if it's blood. Is it watery? Is it pus? Is it milk? Just to mention it, a woman who's got a breast mass and then they are lactating and then milk comes out, that's a galactose. We're going to talk about these things on other videos. Okay, so you want to know if they are having any mass. You want to specifically ask, are they having any mass in the axilla or any swollen node in the axilla? So you want to know if they've got any skin changes, like an ulcer or any other skin change. So that's what you want to know. Like I said, this is an overview, guys. So as you start, you're going to pick up other things that you can ask the patient as well. You can ask the patient as well. So after that, what do you want to do? That's your history of the presenting problem. Then you want to go to your family history. And then you want to go to your past medical history. You want to go to your surgical history. On the family history, what you want to know, there is any history of malignancy in the family, any type of malignancy, and especially also breast and ovarian ovarian malignancies, and also other GIT malignancies as well. What you want to check, if remember, a major risk factor for a breast cancer is that BRCA1, BRCA2 gene. BRCA1 and 2 gene. BRCA1 and BRCA2 gene. A BRCA1 and the BRCA2 gene, these are anti-oncogenes. So they prevent the patient from getting cancers. So when that gene is mutated, it puts the patient at risk of developing a breast cancer. So it's called the BRCA1 and the BRCA2 genes. So you don't want those to be mutated. So people who get breast cancers are people who inherit a mutated BRCA1, BRCA2 gene. So that's the family history. Then past medical history. It's not unusual for these patients to it's not unusual for a patient to present with a breast cancer on the side, on the right, when they have been treated for a breast cancer on the left, or vice versa. So you want to know that as well. So that's also a part of your surgical history, if they've been operated, if they've also been managed or operated for any kind of a cancer, and also other drugs that they are taking for other conditions as well. Once you do that, you move on to your triple assessment. What's triple assessment? Triple assessment basically means that it's how you want to assess this patient. You want to assess them according to this triple assessment. Number one is physical examination. Number two is imaging. While I'm still at this, remember, a breast mass can either be benign or it can be malignant. So the triple assessment will help you as you take your history. Sometimes you can just use your history to decide if this is the chances of this being a benign or being a malignant mass. Sometimes your history can help you with that. But if you are struggling, then you have got to go through all of this to make sure that you can decide, is it malignant or benign. So basically, if you've got a mass that you don't know, going through this will help you to decide at the end of the day, is this benign or malignant? Remember, we can't use clinical judgment really to decide if something is malignant or benign, not unless it's just a pure cystic mass that is there. But any other mass that is not cystic, clinically you cannot really tell if it's benign or malignant. So it's worth going through the triple assessment route. So on your physical examination, what do you want there? So you want to do your inspection. On your inspection, what are you looking for? So this is best done. You need to ask your patient to sit, and then they must undress up to the waist, expose both breasts, and as you look at them, you compare the breast. Is there any obvious asymmetry between the two breasts in terms of size, any masses that you can see, any ulcer, any obvious discharge, any skin color changes, the orange appearance, any dimpling of the skin, any mess that you can see there, and so that's your inspection and other things as well. And then when you come to your palpation, on the palpation, remember, a breast is something like this. Okay, let me draw it like this. Let's say like this. So as we examine your breast, you divide the breast into quadrants, and as you palpate, some people will do it clockwise, some do it anti-clockwise, the palpation. There are two techniques that have been taught. There is this one that you use the whole hand, and then there's this one that you use only the tips of your 4 fingers as you do that kind of movement, trying to locate for a mass. The minute you locate a mass, you wanna feel if it's adhering to the skin. Is it like attached to the skin or the surrounding tissues? Is it mobile? Is it painful? Is it cystic? Does it feel like there's fluid inside, or does it feel like it's a solid mess? Is it tender? Those are the things that you want, and you want to know which location is it when you found it, so it becomes easy for you to do follow-ups and also to do an FNA. If you choose to do an FNA, you know where the lump is. You can even attempt to express whatever that might be coming out of the nipple, be it a pus or a discharge or milk, whatever. You want to try and see what's happening there. That's your physical examination. Obviously, you will do your physical examination now, your systemic, and check, especially if you have a patient that already they've got obvious stage 4 sort of, they're already stage 4 breast cancer. So you want to check if there are any like jaundice, to tell you that maybe the liver is involved, ascites, they're in distress, respiratory distress, like they are having a chest involvement, like lung involvement, or those kind of things. So you want to check bony pain as you examine them. But if someone that is just having a breast mass, and then it's you have got no suspicion that they are having advanced malignancy, then it doesn't really matter. But yeah, so physical examination, and then the next thing that you do, imaging, can either be an ultrasound or it can be a mammogram. An ultrasound is a bedside thing that you can quickly do, but a mammogram, it's like a specialist kind of a thing. You need to refer these patients to be done at a tertiary institution. You don't really find mammograms in district hospitals and some regional hospitals, and these, they normally take longer. They normally take long. When you book a patient, they normally accept patients like the dates are like very far. So this one is like a bedside. If you've got someone, a doctor who's experienced in doing ultrasound, they can quickly check for you. Yeah, so this one can help you with deciding if it's the mass that you are feeling, whether it's cystic or it's solid. A solid mass has got higher chances of being malignant compared to a cystic mass. If it's cystic with fluid, you've got a chance to aspirate the fluid and send for cytology. And also, so it can sort of give you an idea of what is happening. It can also help you to do an FNA that is guided by the ultrasound, and also pick up other masses that maybe you couldn't pick up with the ultrasound. But this is the number one. The mammogram is very good picking up malignant lesions. It's a gold standard. But now, once you find that, okay, this patient actually has a solid mass, because this is what we want to talk about. Because I said we want to talk about malignancy here. We'll talk about the conditions, benign conditions of the breast, but today I want us to talk about malignant conditions. So chances are, if we're saying malignant, this will be solid. So we're going to follow this route, solid. And also here, it's picked up by the mammogram that there's a suspicious lesion. If a mammogram comes back saying that there's a suspicious lesion, then they describe, and it meets the features of a malignant lesion. So what you want to do there, you complete your triple assessment. The third one here is histology. So histology, it means now you're going to do a biopsy here. Normally a true cut biopsy. So you do a biopsy. When you take that tissue to the pathologist, you are going to get a report that will tell you 5 things when that report comes. That report will tell you about, it will tell you, number 1, whether the mass that you did a biopsy on, whether it's benign or malignant. If it's malignant, it's going to tell you if it's lobular or ductal. Remember, if this is the breast, a breast has got ducts, and then at the end there it has got lobules. They've got this grape-like appearance. In each breast you find about 6, 7, 8 of those. So if a cancer is said to be lobular, it means it's affecting the part that looks like grapes. But if it's ductal, the ducts that drain the milk from the lobule. If the cancer is lobular, it can be lobular carcinoma in situ, or it can be invasive. Even the same this side, ductal carcinoma in situ or invasive. So the word in situ means that the cancer is not invasive, so it doesn't go past or go through the basement membrane. If this is the basement membrane, so these are the cells, they are just sitting here. That's in situ. But invasive cancers, they go through this basement membrane. They do like that. So these are true cancers. In situ, these are not true cancers, but with this one, there is a high risk that it might become invasive. So they are still managed. So when it comes to invasive ductal cancers, there are 5 of these types. Number 1 is the papillary. Number 2 is the medullary. It's not really important to know this. It's nice to know them, but we are not expected to know these things as medical students or as interns and even medical officers. Medullary mucinous and cribriform. Those are the types. I'm not sure if I'm forgetting one. So those are the types of these cancers. So now we said that once you do a biopsy, you take the specimen to the pathologist, they will tell you about this, whether it's benign or malignant. Number 2, they will tell you about the yes, I said benign or malignant. Number 2, they will tell you if it's lobular or ductal. Number 3, they will tell you if the receptor status. So a tumor can have receptors for estrogen. That means it's ER positive, or it can have receptors for progesterone, or it can have receptors for what is called HER2. So a cancer that has receptors for estrogen, it means that cancer is dependent on estrogen to grow. Same applies. A cancer that has got receptors for progesterone, it means that type of a cancer is dependent on progesterone to grow. The same thing applies with the HER2. So which means the management of these kind of cancers, if you deny them estrogen, they won't grow. If you deny them progesterone, they won't grow. But if they're not dependent on that, even if you deny them, they will still grow because they are not using your progesterone or your estrogen or your HER2 to grow. Those cancers, they are cancers that do not have any of these. Those cancers are called triple negative cancers. They are very aggressive, and it's very hard to manage because you can't use your tamoxifen or your trastuzumab and all those things. So they are but we're going to talk about these things on another video. So number 1, number 2, number 3, number 4, you want to know, what am I missing here? The last thing is is the Ki-67, which is like a proliferation index of the tumor. I think I'm forgetting the fourth thing there.